My name is Benjamin Moats, and I am the first year HPB Surgery Fellow at Atrium Health. Today, I will be presenting validation of Japanese difficulty score in robotic hepatectomy. These are my disclosures. Dr. John Martini is a paid consultant for Intuitive Surgical. Modern liver surgery has benefited greatly from advances in perioperative care and surgical technique, as well as a number of innovative technologies that have significantly reduced morbidity and mortality associated with these procedures. One of the major advances over the last 30 years has been the adoption and development of minimally invasive techniques, beginning in the 1990s with laparoscopy. Since that time, numerous studies have shown improvements in outcomes with decreased operative morbidity, shorter hospital length of stay, improved patient-reported outcomes, including postoperative pain and quality of life. As utilization of laparoscopy increased, the first World Consensus Conference was convened in Louisville, Kentucky in 2008, leading to the publication of the Louisville Statement in 2009. This established definitions for laparoscopic hepatectomy and specified indications for considering laparoscopic resection, including small peripheral lesions or those in the left lateral sector. These recommendations were based on the understanding that laparoscopic liver resection is technically demanding, requiring experience with both advanced liver surgery and advanced laparoscopy. Given the implications of the Louisville Statement, it became important to develop systems for identifying which liver resections could be completed laparoscopically for surgeons at all points on their learning curves, using data that was immediately available preoperatively. The most prominent of these was published by Bon et al., widely known as the Japanese Laparoscopic Difficulty Score, which incorporated tumor location, size, and proximity to a major vessel, as well as the extent of liver resected and baseline liver function to assign a score of 1 through 10. This score is then used to classify a laparoscopic difficulty score of low, intermediate, or high. This laparoscopic difficulty scoring system had a high degree of correlation with surgeons' subjective assessments of difficulty of operations, and increasing difficulty was associated with increased estimated blood loss, OR time, complication rates, and hospital length of stay. Subsequent studies have externally validated the scoring system for laparoscopic hepatectomy, but until now it has not been validated for robotic hepatectomy. So we performed a retrospective review of our prospectively maintained REDCap registry, which captures all HPB procedures performed in our single regional tertiary care center with a high volume HPB practice. The database was retrospectively queried for all minimally invasive liver resections performed from January 2008 through March 2019. Analysis was performed exclusively on patients who underwent robotic resection. Patient charts were retrospectively reviewed and data was collected, including patient demographics, preoperative characteristics, intraoperative details, and postoperative outcomes. Resections were categorized as either low, intermediate, or high difficulty, according to the Japanese difficulty scoring system. In total, 657 patients underwent minimally invasive hepatectomy during the study period. 241 of these were completed robotically. However, 104 lacked data to accurately assign a laparoscopic difficulty. Of the 137 patients included in the analysis, there were 25 low difficulty resections, 58 intermediate difficulty resections, and 54 high difficulty resections. There were no significant demographic differences between these three groups in terms of age, race, gender, or BMI. However, reoperative hepatectomies were more likely to be classified as low difficulty as compared with intermediate and high difficulty. In this cohort, there were 28 major robotic hepatectomies of at least 4 contiguous segments, and 25 of these were classified as high difficulty with a significantly higher median laparoscopic difficulty score of 8 compared to a median score of 5 for the 109 patients who underwent minor resections. This should be expected based on the classifications as laid out by Bond and colleagues. Intraoperatively, high difficulty score was associated with significantly longer operative times, increased estimated blood loss, and increased need for blood transfusion. Postoperatively, high difficulty was associated with higher rates of post-hepatectomy liver failure at 16.7%, compared to 5.2% for intermediate and 0% for low difficulty resections, with a p-value of 0.018. Overall, clavien-dindo complication rates within 30 days were similar between the groups, with a trend towards higher rates of complications with higher Japanese difficulty scores. Median and mean length of stay were longer in patients in the high group at 4 days compared to 3 days in the intermediate group and 2 days in the low group. Notably, even major hepatectomies go home an average of 5 days postoperatively. 30-day readmissions and 90-day mortality were similar between the three groups. In conclusion, increasing Japanese difficulty score is associated with multiple indicators of operative complexity, including a greater extent of resection, increased operative time, higher estimated blood loss, greater need for blood transfusion, higher incidence of post-hepatectomy liver failure, and longer hospital length of stay. This provides the first validation of the Japanese difficulty score in a cohort of patients undergoing robotic hepatectomy. HPB surgeons who are early in their robotic learning curve should use the Japanese difficulty score to identify patients who are appropriate for robotic hepatectomy. Thank you for your attention.